Thank you very much. Okay, welcome to this morning's meeting of the West Yorkshire Joint Health and Scrutiny Committee. I'm Councillor Hutchinson, Deputy Chair, standing in for Councillor Smage, who unfortunately is unwell. We send her our best wishes for a speedy recovery. Do we have any other apologies for absence?
We do, Chair. Yes, we've got Councillor. Sorry, I've just closed my document down that had that on there. We have Councillor Andrew Soloway, Councillor Liz Smage, Councillor Howard Blackburn, and we have one other. Sorry, I have just closed my document down that had it on. Apologies. Andrew Scopes. Sorry, Councillor Andrew Scopes.
Okay, thank you very much. Members will have had the minutes of the previous meeting from the 15th of March, sorry, the previous meeting in front of them from the 16th of January. Are there any, do they form a correct record? Is there anyone willing to propose them as a correct record? Well, I will. And seconded by Councillor Swift. Thank you very much. In terms of members of declarations of interest, members will be asked to say if there are any items on the agenda in which they have a disclosable pecuniary interest or any other interest which may prevent them from participating in any discussion of the items or participating in any vote upon the items. You can either disclose those interests now or when the item comes up for discussion. Do we have any public deputations?
None received, Chair.
Thank you. So we'll move on to agenda item 5, which is a report on the health inequalities and prevention strategy of the Integrated Care Partnership. Who is going to speak to that?
I think it's Kathy and I, Councillor Hutchinson. Shall we introduce ourselves? Oh, sorry, did Ian want to come in?
No, I was. Sorry.
Yes, on you go, Ian.
Yeah, I was just going to introduce Kathy Elliott, who is the chair of the ICB and the deputy chair of the Integrated Care Partnership, and you were keen that she joined for this conversation, and Sarah Smith, who's a consultant in public health and deputy director in the ICB. And I think Sarah's prepared the paper and is going to introduce the item. And obviously my name's Ian Holmes. I'm director of strategy and partnerships with the ICB, and sincere apologies, my computer's decided that my camera doesn't want to work this morning.
All right, that's okay. The same thing afflicts quite a few of us. Thank you very much. Welcome, Kathy and Sarah. If you'd like to kick off, and you can assume that we've read the paper that members have read the paper that's before us. So,
Great.
If there are particular aspects you want to draw our attention to, feel free.
Excellent.
Thank you. Sarah, should I just give an overview of the partnership? I can do that in a couple of minutes.
And then I've got some slides to share, if that's okay, Councillor Hutchinson.
Yep.
So good morning to you all. Hello, my name's Kathy Elliott. As Ian says, I'm chair of NHS West Yorkshire Integrated Care Boards, which is the coming together of the 5 former clinical commissioning groups under the Health and Care Act 2022. So the organisation has been a statutory body since July 2022. I'm also deputy chair of our Health and Care Partnership, which is chaired by Councillor Tim Swift and brings together council leaders and chairs of health and wellbeing boards and council chief execs, along with NHS and voluntary sector leaders. We meet every quarter to oversee the 10 strategic ambitions that we have and other risks and opportunities across health and care in West Yorkshire across 5 distinct places. And the topic today was particularly reviewed and discussed at the Partnership Board meeting in December last year when we met together at Halifax Town Hall. We had a meeting on the 5th of March, which is our most recent meeting. And if you haven't seen those documents, there's a variety of things, including on how health and care responds to climate change, keep it local policy, and also the Fair Work Charter coming from the West Yorkshire Combined Authority. So we've worked together as a partnership since 2016, and there are a variety of ways in which we work together and particularly manage risks in health and care, and also are each other's critical friends. So thank you for inviting me to come and join you again today, and I'm going to hand over to Sarah, who's going to talk through her presentation.
Then thank you, Kathy, and thank you, Chair. And for those who've just joined, because Ian introduced us, but just in case you weren't here, my name's Sarah Smith. I'm a consultant in public health working at West Yorkshire Health and Care Partnership and Deputy Director for Population Health. So all things public health. As you said, Cheryl, I assume you've read the paper, but I've prepared some slides just to sort of guide us through, because I appreciate it's a long paper because there's lots going on, and the topic of health inequalities is quite broad. So I've got some slides to guide us through, then happy to take any questions or comments as they arise. So I will share my slides. Here we go. Can people see those slides?
Yes.
In presentation. Excellent, thank you. So the health inequalities work that we do, health inequalities, just to give that kind of step back in that overview, what are the unfair and avoidable differences that we see between different population groups? So that could be related to where you live, it could be related to your ethnicity, your age, or any other protected characteristics. One of the areas we do focus on, though, in our 10 big ambitions is the inequalities related to where you live and related to deprivation. So that will be a theme throughout these slides and throughout the paper. But we do focus on some other areas that we think make sense to work on at scale. And the inequalities work, again, in this paper, we're going to focus on the work where we've come together collectively as a system. But most of the work, you'll be aware, happens and is led by our local authority directors of public health and public health teams in our local places and communities. So this paper provides an overview of where we've come together to work on things. But there's much more work going on across West Yorkshire to understand and address inequalities. So in the paper, we've summarised that the work we've done since the strategy was set in 2020 up until present day. And we've summarised that around capacity, capability and intelligence. So the capacity piece is where we've been able to bring additional resource into West Yorkshire to do targeted projects to address health inequalities. The capability piece is around where we've tried to upskill the system and people who aren't necessarily public health trained in their understanding and awareness of inequalities, and help them to take action to change things to reduce those differences that we see. And the intelligence piece is where we've not quite known enough about certain population groups. We've either commissioned or participated in research to further our understanding of those areas. So this is a summary of those areas in the paper. So starting in July 2020 and throughout 2020, we did some work where we put some targeted funding towards local communities to reduce inequalities. In 2020, we also launched our Race Equality Review with an action plan that is owned by our partnership board that looks at the inequalities in West Yorkshire in relation to race. And I did come and present on that paper, I think back in 2020 or 2021 to Joint Overview and Scrutiny Committee. In 2021, we launched our Health Inequalities Academy, and that's a space where we bring people together in West Yorkshire to learn about health inequalities. It's been nationally recognised, and it was the first one in the country to be launched by an integrated care board, and it's been replicated since in other areas. In 2022, the beginning of 2022, we were able to secure £1 million of NHS resource to be targeted towards fuel poverty, and that was a decision made by our partnership board that Kathy was just mentioning, to really invest in those determinants of health and to look at how we could use NHS funds to reduce inequalities in the way that people live and how they access services. Following that, further on in 2020, we launched our Health Equity Fellowship, and that gives people protected time to learn about health inequalities. So I think we've had an elected member on there. We've had members of Wakefield District Housing. We've had Kathy was a fellow as well, and we've had clinicians and members of general NHS staff, and that gives people protected time to learn about health inequalities. And that equity fellowship is again something that's we were the first to do in West Yorkshire and has been replicated nationally. Later on in 2022, we did some targeted work looking at how we can ring fence resource for action on health inequalities, and that was what we've called the Core 20+5 resource, and that was some national resource that came from NHS England. Some other ICBs weren't necessarily able to secure that for really focused investment on health inequalities, but I'm proud to say we did in West Yorkshire, and that meant £11 million of investment going in the system level and in local communities to make targeted improvements in health inequalities. Later on in 2023, we were the first ICS to be awarded a Partnership of Sanctuary Award, and that shows our commitment as a health and care system to people seeking sanctuary, and so that we're a migrant-friendly system. Later on in 2023, most recently, we launched our Fair Work Charter, which looks at addressing inequalities in the opportunities people have in relation to work. And then most recently, we launched our Inclusion Health Unit, which looks at targeted work for specific communities who are small in number but really high in need. So rough sleeper populations, gypsy and traveller communities, people seeking asylum, etc. And then today, actually, we've just launched our West Yorkshire Tobacco Alliance, and that is meeting at the same time as this group. So that's a bit of a summary of what's in the paper and a bit of a flavour of work to date. I think the other thing I wanted to highlight is the work for 24-25. Again, there's some more detail in the paper, but the 4 areas that we really wanted to focus on to balance that targeted work on prevention inequalities, but also against the backdrop of the financial challenges we're facing across the whole health and care system. So the 4 areas we're focusing on for 24-25 are some targeted work looking at those causes of ill health in the first place, so things like the Fair Work Charter and Inclusion Health. Targeted work on risk factors, really looking at tobacco and smoking cessation. Some work on our long-term conditions pathways, so looking at early diagnosis and prevention for people living with long-term conditions. And then again, we're looking at that overall system leadership and how can we do more better to be an equity-based system? How can we embed approaches to reduce health inequalities in our leadership? I've got some detail on here. It's in the papers, and I'm happy to share these slides. And these are some detail of each of those areas. So for the determinants of health, a lot of that focus around our West Yorkshire Health Inclusion Unit. So we've got some aims there for improving what we know about these population groups, because data's not often collected well for these groups. So we've commissioned specific health needs assessments so we can understand more, for example, for the needs of our gypsy and traveller population, our sex worker population. We're setting up a community board for this Inclusion Health Unit as well, so we can learn directly from people with lived experience, because that's really important in making the changes to the services. We will continue our commitment to be a partnership of sanctuary and continue to deliver services and make changes to support that. And again, we've got other pieces of work in train for these specific groups. So we've got a project about to kick off in the new financial year for improving respiratory diagnosis for our rough sleeper population that we're supporting as a health and care partnership. It's a bit of a flavour of the determinants of health work. For the tobacco control work, these are the key aims for the Tobacco Alliance. Again, we're focusing on how we can support the work that already takes place in local authority and come together to think about what we want to do as a system. So we've got some requirements from NHS England, which are the long-term plan ones, which are detailed in the paper about embedding stop smoking services in our hospital trusts and our maternity and mental health trusts. We've got a Swap to Stop campaign, making use of vaping options for people who are existing smokers. And it's very targeted on just that cohort. We've then got some work on supporting our West Yorkshire approach to reducing illicit tobacco, and focusing as well on other parts of the system where we know we come across higher levels of smoking. So, for example, our emergency department and people living in social housing and working with housing providers there. So that's the flavour of our tobacco control work we've got planned. For long-term conditions, we really want to focus again on using that data and intelligence to look at our key long-term conditions that are driving the health inequality gaps we see. So we're going to have a really big focus on our heart, our kidneys and our lungs in 24-25, working with our local places to see what are the differences we can make around earlier diagnosis and better treatment. So we're looking at the data at the moment, and we're going to take an intelligence-led approach on that. To support all of that, we know that people are people. They don't just live with one of those conditions. So again, we're maintaining our focus on personalised care and supporting people who are living with complex trauma as well, to support them to manage their long-term conditions. And then finally, as I've said, we will maintain that focus on being a system that supports health inequalities leadership and helps us make decisions that are based on reducing inequalities, even in this tough financial climate. So we'll continue in the Health Equity Fellowship and the Academy. We're signing up to the Keep It Local principles that support a shift towards prevention through working with the voluntary and community sector and working within our local communities. We're revisiting our rate equality review and seeing if the outcomes there are still fit for purpose, and we're agreeing those future objectives in partnership with people in the voluntary community sector that work directly with those communities. We're continuing our focus on trauma and adversity and resilience, and we're going to focus on measuring the impact that's having this year. And again, that focus on resource and targeting our resource, our overall pocket of resource we've got for West Yorkshire to the communities that need it the most. And I'll just finish on why we're all here. We've focused a lot on the data and the intelligence, but what we also hone in on is the stories that we hear from these individuals, because we can use the data to find out where we want to make a difference, but how we make a difference is very much led by engagement with these local communities. So I will finish there, Chair, if that's okay, and stop sharing my screen. Thank you. I'm happy to take any questions or comments.
Thank you very much for that, Sarah. So do members have any questions? I'll kick off if I may. You've mentioned your work on tobacco, but we know how addictive nicotine is, and the uptake of vaping, particularly amongst young people, is quite alarming. That we're busy getting a whole generation hooked on nicotine, even if it doesn't have the same cancer risks. It has a very similar cardiovascular risks. Is the tobacco strategy doing anything about vaping?
Yes, so there's a couple of elements on the vaping work. So it'll be picked up through the Tobacco Alliance as well, and is very much being picked up in our local places through local authority public health teams. And part of it is building that evidence, and part of it is supporting people not to start vaping in the first place. I think the Swap to Stop initiative I mentioned, we've been really, really clear, and it was one of my concerns as well, is that we keep that very distinct and discreet people who are existing smokers, where we know the evidence base helps, but also we have that focus on stopping young people starting vaping or smoking in the first place. So it will be part of that Tobacco Alliance work, definitely, and I can feed that into there. Like I say, they're meeting right now to discuss their priorities. I can feed that in, but thank you. Yeah.
Thank you. Councillor Swift.
Yes, Chair. Right at the very end of the report, the words are there, and help to break the inverse care law, which currently sees lower levels of service provision in communities with higher levels of need. Now, there was a little bit that was said right at the very end of the presentation in terms of work on heart and liver and so forth. But for the most part, the report, and I think we can all understand bureaucracies and how things happen or don't, but for the most part, it appeared that the burden of addressing health inequality was going into the public health silo, and didn't really, and the rest of the health service kind of said, oh, right, you know, that's something for public health to get on with. But the issue of dealing with that issue dealt with in that half sentence at the very end, where it says the inverse law, where the communities with the highest need tend to get the lowest provision. Now, I just wondered, and I don't know who would answer on this one. I just wondered if it was possible to address that point, please.
I can make a start, and then I don't know if Kathy wants to join from a overall system perspective from the conversations we'd have at Partnership Board. But absolutely, I think public health can influence, and I think that's our role. We've got the skill set to influence that resource spend, but actually how it's allocated, we work really close with our finance directors to look at putting the resource in the communities that need it the most. So I think where we're talking about that public health input, that's supporting our whole system to understand that inverse care law and understand that these communities are higher in need and will have often less resources. We've made a start. We've done some work on the vaccination campaign that's listed in the paper. And we've made a start again in our local places, targeting that core 20+5 money we talked about. That's very much headed towards local communities and local GP practices, and is targeted more in areas with higher levels of deprivation. But again, I think that's that whole system approach to looking at how, as public health, we can influence, but as a system, we need to make decisions around allocating resource where it's needed most. So really welcome question.
Thank you.
Councillor Hutchinson, can I respond as well?
Yes, please do.
So Councillor Swift, there are lots of different examples, and my colleagues and I can put some things in the chat box, but I'll give you an example of, I suppose, the NHS working with local authorities and public health, which is Leeds Population Health Board, where they are looking at local data. They can go down to postcode, if not street by street, to identify communities and families that are in need, exactly as the communities and families that you're describing, and then to be able to tailor healthcare services. So Leeds Places Population Board is a really good example. There are other things in Leeds, for example, like Home First, where the NHS and local authorities are working together to make sure that people are, particularly vulnerable people, are getting the support they need and avoiding hospital admissions. So there are lots of examples across West Yorkshire, and one of our jobs as NHS West Yorkshire and through the partnership is to make sure this good practice is being shared and spread elsewhere. We have just supported a new community services provider collaborative that brings together GPs, NHS community services, the voluntary sector, district nursing, for example, to share best practice, particularly in supporting vulnerable and families and communities that are in real need. So there is good work there, and we're a system that value public health, that then we can bring it into healthcare. So we'll put some links in the chat box, but I don't know if Ian, my colleague Ian, wants to follow up as well. But this is something that I'm wanting to make sure that we work on very thoughtfully.
Do you mind, Councillor Hutchinson, if I just
No, on you go.
Quick point? I think it's a really great question, Councillor Swift, and I think it's a great question because the focus nationally around access targets can actually widen inequalities, because some population groups are able to manage the system, if you like, work the system to get access to care faster, and those groups tend to be the groups that have got overall better health. So making this kind of insight and this work that Sarah's describing a core part of our business is really, really important. The example that I think we've shared with you before is if you look at ambulance conveyance times, there's an inequalities gradient to those. If you look at people waiting a long time for elective procedures, planned care procedures, those affect some communities much worse than others. So a big part of this is trying to make sure we're taking that inequalities approach to even the sort of the core NHS standards, because if we're not mindful of those and if we don't pay sufficient attention to those, we inadvertently can widen inequalities. So that's a big part of the work as well. Thank you.
Councillor Coates.
Hi, morning, Sarah. Sorry, I had technical problems at the beginning, so I had to reboot the PC, so that was why I was a bit late joining. I would like to ask, where does trying to improve cancer screening uptake rates fit into this piece of work? So we've got some really great collaborative and partnership working going on in Bradford, because the screening uptake rates are below the national average. For example, only 50% in City Ward attended mammogram screenings when invited, versus 71% in the more rural and affluent wards. So language barriers, transport, not understanding what's involved in a mammogram were all like raised as issues and barriers to go for the screening when invited. And as I say, we've got some really great work going on in those communities, which are probably, you know, they're not understanding what's involved. And we've, as I say, we've got this really great collaborative work going on. So I just wondered where it all fits in. Thank you.
It very much does fit in, and I think it's how we classify the long-term condition stuff in the paper, probably, which is why it wasn't included, but it very much is there. And the Cancer Alliance in West Yorkshire, I know there's loads of really good local examples, so I'll give you a few of where it fits in, but particularly from West Yorkshire point of view, the Cancer Alliance actually has a health inequalities programme manager themselves that has a real focus on targeting reducing inequalities in screening and early diagnosis. And they've done some fab work, both around deprivation ethnicity, but also around some of the inclusion health groups. So they did some work with our trans communities around cervical screening uptake, for example, which was quite innovative. And I know the work on lung health checks have had a real focus on inequalities in relation to deprivation. So you're right, Councillor, it's not reflected, Councillor Coates, so it's not reflected well enough, I don't think, in the paper, but it's absolutely there. And it's also this core 20+5, which is very much, I apologise, NHS management speak. One of the key priority areas for that is cancer. So the money that we've flowed down, some of our local places have chosen to focus in their local communities on reducing uptake in cancer screening through that resource as well. So there's different pockets and approaches to it, but then there's a whole system approach through our West Yorkshire Cancer Alliance, which very much take the inequalities piece seriously. So thank you for raising.
Yeah, I just wanted to say one really good thing that we've done in the communities is we've taken the screening van to like a supermarket and shown and asked some of our councillors to bring in their constituents, and we've shown some of the ladies what's involved, and we've had really good, you know, they've said, oh, is that, you know, I've not answered, I've had a letter and I've not been, but now I've seen what's involved, I'm going to book an appointment on Monday. So that's had some really, really good positive uptake. Thanks.
Excellent.
Thanks.
And the other group I'll just quickly mention, again, at West Yorkshire level, because the numbers are small, we're doing work with gypsy and traveller populations because we know their screening uptake rates are really low. So we're doing some targeted work with them. And we started the conversation through flower arranging. We went in through that route because that was how we got in through the door. So yeah, like you say, we're trying those different innovative approaches. But yeah, really great to hear. Thank you.
Yeah. And hopefully word of mouth will help spread through those communities as well. So Councillor Jamil.
Hi, good morning, everyone. Thank you, Sarah, for your paper and your presentation. I found it really interesting. Just a couple of points. I just want to echo what the chair was saying about vaping, especially around children. I think it is a massive issue and it's something which concerns us in Bradford. So it's good to see that it's part of the you know, your programme and that you are taking it seriously, and we're hoping to do a bit more work around that in Bradford, so hope to sort of like work and tap into some of your work when we look into that. What I wanted to ask about is I don't see any mention of any work around diabetes in your plan. It may well be there, but it doesn't come out in the report, and I think as a long-term condition, I think it's really, really important that that is included in some of your work. You know, I know there's lots of work locally going on in terms of prevention and education, and trying to stop people from becoming diabetic through lifestyle and exercise, etc. But I don't see that as a priority in your paper. Is that something you're looking at, or is it not something which is seen as a issue in West Yorkshire? Because I know it certainly is in Bradford.
It definitely is an issue across West Yorkshire, and again, it's I think it's just the clarity within the paper. But no, thank you for raising it, Councillor Jamila. You're right, part of the cardiovascular disease and the healthy hearts prevention really links across to the diabetes. So that on that level, there's some links in terms of preventing diabetes and diagnosing early, because we all know if we diagnose early, we can get the best treatment and support. So
Absolutely.
That falls within that healthy heart space. We do also have some really specific targeted work that comes in through NHS England that's we're responsible for commissioning around the diabetes digital weight management programme in West Yorkshire that falls within the population health team, and I've probably not detailed it enough in the paper, and I realised by the time I got to the slides, and again we've got a real focus on inequalities for that, because what we don't want to do from a digital inclusion point of view is to be putting an offer out there that isn't acceptable to everyone in the population. So very much a focus and very much a need, as you'll understand, in West Yorkshire. So it's coming through our long-term conditions work. Some of it's linked to that prevention end, but we do appreciate there's some diabetes specific treatment work as well. And we've got a really keen clinical lead working with us on it called Wakas as well. So yeah.
I think some of the work you've mentioned around the long-term kidney conditions as well. I think that diabetes plays a huge part in some of the kidney conditions which people have. So it'd be good to see all that linked in. And I'm all for doing all the education and early prevention work, especially in some of our communities where health inequalities are so stark, because it is sometimes as a result of poor diet, poor lifestyle, which leads to these conditions. But thank you for that. And,
thank you.
Appreciate it.
Councillor Rhodes.
There we go. Thank you, Chair. Thank you for the report, Sarah. And while I've been here, I've actually delved back as well into the diagram that you show your movement and process since 2018, when the integrated care system was set up. I was actually a member of that shadow committee at the time. So obviously I'm keen to be able to measure what improvements have been made in the last 6 years. I note that you also had a refresh and review, I believe it was in 23. But what I don't see in the report, I don't see in the refresh or given us details today of actually outcomes. What's been achieved? You can set up a myriad of groups, actions, projects, which seems to be the way things are done these days. But in order to know if they've actually been successful in doing the work that you intended them to do, you need to have outcomes and deliveries. And it's the same in any organisation. If you don't have those, then when you go to review again, you don't know where you need to review. So the question is, why aren't we seeing any outcomes of projects that started from the Integrated Care Board, I suppose then devolved to places? Why aren't we seeing outcomes and benefits? That's the first one. Secondly, smoke and cessation has been on the agenda since I've been involved with the scrutiny process for over 13 years. For instance, they went really hard on it and actually made it a regulation that nobody could have a vape unless they were actually diagnosed by a doctor on prescription, which I think is marvellous. And that is a big issue, as my councillor colleagues have said, across all the patches. Now, through your health inequalities, etc., and the prevention of health inequalities, what measures do you have in place in terms of the age group of children now who are vaping? They're actually swapping vapes, I'm told, under doors and toilets, where some schools have had to put some measures in to try and prevent this happening. I'm a person of outcomes. I love to see what's going to happen, but I want to see what is achieved. And I think that's really important. And I think as far as my colleagues here, in terms of other issues, I'll give credit to the projects that you're looking at, but some of these have been on the agenda for years. And what I'd like to see with those outcomes would be, as well as that, where in circumstances it hasn't worked. Because if it hasn't worked, then you need to have some more input into that project. And lastly, I don't know about any of my colleagues here today, and it may be a topic that somebody within public health within the ICB has actually considered or may consider in terms of the public health agenda, because they're all linked. Has any thought been given through the ICB on the issue that's now a very worrying aspect of health? And it's not just relative to inequalities, but it can be the measles outbreak that's up and down the country. I've been approached only last Monday by a lady who said, if we're doing an investigation, this is why I'm asking the question today, if we're doing an investigation or information given about it, she was willing to come forward as a witness to what happened to her getting measles when she was young, which has had a consequence on her health permanently. So I know I've put down a lot of questions there, but I think they're all very relevant, because at the same time, we've had the cost of living crisis, and I don't know how, and that is an inequality in itself. I don't know how you've actually built that in through the ICB board in connectivity with the local place and the local public health agenda. Thank you, Chair.
Okay, thank you, Councillor Rhodes.
Shall I start with the
Sarah,
response? I
if
think
you
Ian might come in around measles, and I can add to that as well after Ian's come in. I'll start with the outcomes bit, Councillor Rhodes, if that's okay. As you've alluded to, with the cost of living crisis and with COVID as well, the overarching indicator around health inequalities, if we were to just measure that, doesn't look great, because it's lots of things feeding into it. So what we try and focus on when we're looking at the measurements, and again we could probably provide more detail against this paper, is those things that we can do that contribute towards reducing that gap in inequality. So what's within the gift of the health and care system to improve as outcomes to reduce that gap. So things like smoking, and I know we've been doing it for years, but we've still got people smoking and we've still got to make an impact. So things like the impact we can have on smoking, things like the impact we can have on physical activity and obesity, but also the impact we can have, as you mentioned, measles, on vaccinations, on access to cancer screening, early diagnosis. So those are the things we all measure as a whole system to try to work towards saying, if we contribute more in all of these things, we can make a dent on the health inequalities, the gap in life expectancy that we see. But it's much broader than the health and care system. The health and care services only make up about 20% of that gap, and the rest falls within where you live and your job and the wider factors and risk factors. So what we can do though in the future is kind of break that down a bit and say, well, this is the dent we've made on smoking, stopping smoking. This is the dent we've made on earlier cancer diagnosis. This is the dent we've made on earlier diagnosis of respiratory conditions. And that's the work we're hoping to do with the long-term conditions programme this year, is to say, where are we not making as much of a dent as we'd like to? Where have we still got those big gaps, and how can we improve? And that's where we really want to be a bit more focused in this coming year. So there have been differences made, but I think we could have done better in this paper in terms of pulling those out a bit more and kind of saying the overarching thing is impacted by lots of different factors, but here are some differences we've made, and we've kind of touched on that with the smoking. But I think, yeah, there's more we could add. definitely to illustrate that and to illustrate those reductions in inequalities. And I think I agree, we've been doing the smoking cessation work for a long time, but it's still not there yet, and we need to get smarter in how we target people, because as the numbers get smaller, the people who are still smoking get harder to treat often, because we're looking at more complex individuals often now. So our approaches need to change, and that's what we're hoping to achieve through the Tobacco Alliance as well. So we're still on with it, but we're taking a bit of a different approach on these things now.
Chairman, if I may comment on the response.
Yeah.
I fully understand the situation, have been around as an elected member for many years. The problem that I see is that we're not getting the information of the changes that you and we would like to see, and it's a demanding challenge. I have to admit, a demanding challenge. But when you're speaking about collaboration and outside of the 20% of the health service, I don't see much of that going on in place, because they're all under such tremendous pressure themselves. And I would like to see some work that you've done on projects as well, because as my colleagues have mentioned, the unknown factor, yes, on the impact on children's health through vaping is dangerous even to consider. And I don't know what work you're doing with education authorities, how out there in place you work through a policy of, from the ICB board, of through the processes of the partners, what connectivity have you in their outcomes that they're working to, so you get the total corporate response. That's missing. And at the same time, I think for the inequalities of health, sometimes some of the schemes to involve the voluntary sector, quite rightly, are used to replace what should be there from the authorities involved. They used to be the icing on the cake, did the voluntary sector. Now they are mainly a third of the cake. But I think the paper is giving us a lot of information. But I'm wondering, Chairman, rather than wait till the next meeting, if it would be possible for our officers here today to actually get a paper together on outcomes of schemes, or those that are in the process of having delivered or to be delivered to the policy and procedure that you've asked. If we could get a report back, and that could be sent to all scrutiny officers across the places, then we could equally take that to our own committees to inform our members of the work that's going on, and make them aware of activities that may be in their own place that members can connect to with information in terms of their own communities and deprivation.
I'm happy to make that recommendation on behalf of the panel, if that could be put together, sort of just showing what impact there has been from the various elements of the program. If that's possible to produce for us, I think it would be very valuable. I'm aware that time is moving on, and we've got a couple of other agenda items. So I'll take a question from Councillor Coates, and then I think we did. I've just got one comment myself, which I'd like to put in as well.
I might be being quite controversial with this, but does menopause fit anywhere into this under the age inequalities? Because Kathy, I want to say thank you to you, because you've made some money available, and we've been doing some work with Helen Farmer in Bradford and Airedale on a new women's health hub, which is targeting menopause. So we've been doing some brilliant work there. It's not quite there yet, but we're on with it. So it's a really hot topic in the media and on TV. So I would say that was an age issue, especially for women around employment.
Yeah, and we're linked into the Women's Health Hub, Councillor Coates, and particularly around inequalities relating obviously to gender and age there, and we're doing some really targeted work there. There's work in place going on, like you've related to the menopause work, but we're doing some work around sex workers across the whole system and their women's health needs as well. But again, that's something else to link in. And as you kind of everyone's demonstrating and illustrating, we're kind of focusing on what we're doing as a whole system, but actually the inequalities piece runs through every programme of work and everything we do. So I think one of the things might be that we, each time a paper comes, we ask for that inequalities angle on it, because actually it runs through everything, rather than, you know, we try and influence it from public health. We've got a small pool of public health expertise, but we try and make it run through, you know, have a health inequalities lens in everything we do. But yeah, very much so that menopause element is an inequality in relation to age, definitely.
For example, in Bingley, an NHS worker set up a support group, and it's now got nearly 700 members.
Wow!
So it's real. It is a hot, as I say, it's a hot topic at the moment. So thank you for that.
Ian Holmes, you wanted to come in?
Yeah, and apologies, Councillor Hutchinson, I am conscious of the time, but Councillor Rhodes has made a really important point about measles, and if I could just respond to that really quickly in 2 minutes, because I'm conscious that there's members of public potentially listening to this conversation as well, and I think it's an important issue. So the councillor is exactly right. There are outbreaks of measles, mainly in the southeast of England and the West Midlands, but the numbers are higher than we'd like them to be. And what we know is that measles spreads really rapidly among unvaccinated populations. So the R rate, which is, you know, the rate of reproduction that we all became familiar with during the pandemic, is 15 for measles. So one person having it can lead to 15 people getting it in an unvaccinated population. And the magic number in terms of immunisation is 95%. If we get it to 95%, that R number drops to less than 1 and outbreaks are prevented. The numbers in West Yorkshire at the minute are 89.8% for the first dose of the MMR vaccination and 84.2% for the second dose at 5 years. And what we're seeing is a slight downturn in MMR vaccination take-up, and I think this mirrors what we've seen in other vaccinations, particularly since the pandemic, including flu and COVID vaccinations. We are really, you know, and as the councillor said, unfortunately, measles isn't just a rash. You know, it can impact on different population groups in different ways and can have quite significant complications. So we're really keen that we're vaccinating as many people in the population as we possibly can. It's not a one-off opportunity. So if families have been offered a vaccine and haven't taken it up for whatever reason, that doesn't mean that the door's closed on them. They can go back to their practice and you know, ask for a vaccine through that route. We're working with general practices across places and public health teams and local authorities around making vaccine available and using sort of routine contacts to increase vaccination rates. And we're also working with communities where we know vaccination uptake is lower to support higher uptake. This, again, it's really relevant that we've picked it up under this item because it's an inequalities issue. We know that the uptake is lower in more deprived communities and ethnically diverse communities, and it's really important that we're supporting people to make informed choice about vaccine, I think, particularly given where we are in measles. Thank you.
And I think that it's very important not to be mealy-mouthed about the potential serious complications, which include death and long-term brain damage. So, you know, that's very rarely actually explicitly stated. And I think we should be making sure people understand what those risks are. As you say, it's not just a rash. Cathy Elliott?
Thank you. Just a few points for finishing up now. Councillor Rhodes, I think you and I are of very similar minds. I want to see outputs and outcomes, very much so. And in being chair of the NHS West Yorkshire Board, I've put quite a few things in the chat box, which may be helpful or not, but one of them is our January board report on performance across the system. So you can see how the NHS is performing, but the middle part of that report is showing how we are starting to look at outputs and outcomes against our strategic aims. So you've got that document there, which is something I'm grateful Ian and others have worked with me on to make sure that we can see that the time and effort is really making a difference. I think the other point on inequalities overall is something I want to do through our NHS West Yorkshire board meetings from April this year, is particularly to look at the theme of inequalities. And Sarah, along with other public health colleagues, are going to provide me and the board with information on the highest and the most prevalent inequalities that we have in our system, and for us to then assess how our commissioning and our NHS services work together on that, which will then be looked at place level and will come into our partnership board as well. So I think the work that we're planning across the NHS West Yorkshire board would complement the request that you've got there, Councillor Rhodes, as well. And the last thing I want to say, which I've also put into the chat box there, is please encourage local citizens, people in your constituencies, to come and get involved. And I've put 2 opportunities there. One's a Cancer Alliance patient panel, and there is also a Maternity Voices panel as well. And there is overall our West Yorkshire Voice, which is really helpful to me as chair of NHS West Yorkshire, because we do bring members of that forum in to talk to us about their experience of services, which then informs our decision making around commissioning as well. You know, there's lots of different ways in which people can get involved, but there's a few forums as well. And Councillor Coates, thank you for sharing that on that menopause service. I'm very passionate about making sure that women's health is, the support for women's health is of a good standard, and the government's women's health strategy is helping us to have those discussions and funding being available. And I agree with you, it's good to have menopause services out there as well.
Chairman,
Chairman, may I come back? May I just come back on something, if I may? First of all, 2 things.
Briefly, please.
Yeah, absolutely. We've got an important topic here today, and I think the presentations have taken too much time personally. First of all, I'm grateful to Ian for coming in on the measles issue. My problem is I don't think that we're getting enough of the publicity about measles out in the areas. I think it's sort of on the back burner. It's very important, and I think we ought to be doing more to publicise how people can get vaccinated. And that seems to be in the wind somewhere, but I'd like somebody in there to actually push that down to places. It's important. Secondly, in terms of the issues that Kathy's mentioned, groups and forums are fine. In particular, they're made up of people who want to be involved. But my problem with them is, who do they report back to? Because if you're having a group and people are going there, who do they report back to? They have an interest, and that's great, and it should be great. But we need a mechanism right through the whole system that where something is happening and we have people going to meetings, that those reports should go somewhere. And then we can all be part of what the action is in terms of knowing what's happening, who's representative, and to know that we do it through our own scrutiny locally. But I think there's a lot more can be done in publicity from the ICB to place, and it is a forum, not just in itself, but collectively you can do a lot more. Thank you, Chair.
Thank you.
Right.
There's always room for improvement, and our involvement framework can continue to do that. So we'll have an evaluation out soon on what we've done well, but what more we can do. So we're always trying to be our own critical friend. And when we ask people to give their time, we also need to tell them what's changed, as well as I take on board what you're saying as well, as they need to come back to forums as well, and local people. But it's really helpful feedback. Thank you, Councillor Hinchon.
Before we leave this topic, I see no mention in the paper about school nurses. Schools have a captive population. We know that the behaviours for the rest of life are formed in childhood. Are we missing a trick in terms of actually getting the good health preservation messages out within schools? I'm concerned that the number of school nurses is falling, the number of schools they have to cover is increasing. Isn't this a resource that we ought to be targeting, or do you have a strategy for promoting good emotional health, sexual health, relational health, nutritional health within our school settings?
I think if I may come in, I'll let Ian come in as well, but our children's and young people and families programme have really good links with our schools and school nursing services. So we don't have the detail in this paper, but we do have strong links in there, because that link's absolutely recognised with the education sector. And the ability to influence health.
Again, I'd like to see the effectiveness of that strategy. So because I'm not aware that it's being used to its optimum effect. But Ian?
Yeah, I mean, I think it's a good point that you raise, Councillor. It is one we'll have to take away and provide something outside the meeting on, I'm afraid.
Okay, if you could again, so outside this meeting, if we can ask for a paper to be a report to be circulated on the outcomes from the programme, and I think we should adopt the request that every paper that comes before us should say how it goes, what contribution it makes to addressing health inequalities across our population. Thank you very much for your presentation, Sarah and Kathy, and it's much appreciated. And good luck with the programme.
Thank you, Chair.
Moving on.
Thank you. I'm going to leave the meeting now. Thank you. Good to meet you today.
Thank you. Moving on to agenda item 6, the West Yorkshire Urgent Care Service Review. Who would like to speak on this? Again, if you can assume that members have read the papers.
Yes. Thanks, Councillor Hutchinson. I'll pick this one up, and I'm joined by my colleague Tessa, whose camera appears to be working, which is good. It's obviously just me that's it's affecting today. Yeah. So thank you, and we've shared quite a lot of information with you on this. And I am conscious that last time we had the conversation, it probably led to more confusion than clarity. So apologies for that, and hopefully I can provide a really succinct overview that sort of sets out where we are with this piece of work and where it's going next. So West Yorkshire Urgent Care is a service provided by an organisation called Local Care Direct. It's been providing that service since 2013. It started as a GP out-of-hours provider across West Yorkshire. But what has then happened since 2013 is that its range of service it provides in West Yorkshire have grown in a fairly unplanned and organic way based on individual decisions taken on different areas, to include things like clinical advice services, emergency department streaming, providing cover for protected learning time for GPs, providing a safe haven service in Collardale, and providing support to urgent treatment centres in West Yorkshire. And like I say, that's sort of grown year on year, and the value of the contract currently is about £20 million. We agree to do a review of these services because, like I say, the nature in which they've grown, the impact of COVID, which is meant to move to more sort of remote and digital approaches to providing support to people, has meant that it's probably not in the optimal position that we'd like it to be. What's really clear, and I want to really emphasise this point, is that this is a piece of work that's been led by the ICB as commissioner. It's not a piece of work that's been led by the provider delivering the service, LCD. It's been led by the ICB with a whole range of stakeholders, including clinicians, the ambulance service, primary care representation, and Local Care Direct. And we've listed the services in the document, and you can see the various services and what's provided in each line. The approach that we're taking to reviewing and hopefully improving this service is what we call a service development and improvement process. And the process that we've been through is we've taken each of those components of service that we've described in the paper. We've said, what's it like now, and what could we do better in relation to each of these items to offer a better service, essentially. And there's quite a long appendix there, and that is the draft of the service development and improvement plan for each of those areas. So hopefully you can see in that annex where we talk about GP out of hours, we talk about the range of things that we're proposing to do in relation to that service to make improvements. That STIP is still in draft. We've had a helpful conversation about it in the task and finish group we've got at West Yorkshire level. We've engaged with the clinical forum of West Yorkshire on it to get clinical advice. We're sharing it with you for comment, and then once we've got that SDIP finalised, that service delivery and improvement plan finalised, we will carry out pieces of work with LCD to implement and deliver those changes, probably over the next year or two, 1 year to 2 years, depending on the specific line that we're talking about. The work has been informed by insight, insight into people's perspectives of the service, and we've shared some of that. We included some performance metrics within that as well. I think that was the version that I'm not sure if that was the final version that found its way to you, but I can share those performance metrics if you've not seen them in the paper that you've got. And we'll continue to be driven by patient insight and the data as we're taking forward these specific proposals in relation to each of these items. I'll pause there, I think, Councillor Hutchinson. Tessa, I don't know if there's anything obvious that I've missed.
Not for me. I think it was a really helpful summary.
Okay, thank you very much, Ian. I think it's important that we realise that the out of hours service is the main part of this. I suspect out of hours actually covers many more hours of the day and of the week than in hours, and people fall ill at all times. So getting this right as possible is really important, and it can't be seen as being a sort of add-on, particularly over long weekends and times like that. I would like just to ask about in work stream 1, where it says scope the plan for online consultations in the out of hours period. And I'd like to know what that actually means, because we've been talking about reducing inequalities, and digital exclusion is a major concern. People where English is not their first language, people with learning disabilities. There's various reasons why online consultation may not be allow for a proper assessment of somebody's problems. So I just wondered what was meant by that section on scoping plan for online consultations. Could you say a bit more about that? Yeah. So I think just to go back to your first point, I think the first point you make is critical. If this service isn't effective and supporting people's needs and helping meet people's needs, you get pressures everywhere else in the system, frankly, and you get a situation where people's needs aren't met in the right way and in the right place. In terms of online consultations, I think, without sounding slightly glib about it, I think they work for some people, but they don't work for other people. And where they work for people, so taking me as an example, it works really well for me. We should be looking to maximise opportunities for people where it's clinically appropriate, and where there's patient demand for it to be able to do that. But what we're not saying, Councillor Hutchinson, and just be really clear on this point, is that it's a movement away from a telephone advice or a face-to-face consultation or a visit service. It's about how we can get the service to operate in the most effective way to meet people's needs. And clearly, Citizen Insight, working with Health Watch and getting the right patient involvement engagement in that work is really important, because linking back to the previous conversation, if we get this wrong, the risk is widening inequalities, and the risk is excluding certain population groups, which is absolutely not the intent to do this. It's about the appropriate means to access for the appropriate population group, I would say. Okay, that's reassuring to a point, but we've seen with so many public services and banking and various other things that what starts with being an optional extra then becomes the position by default. And I just want to know where where we were on that journey, and there isn't the detail in the report to know that.
No, and it's work that will be done. It's work that will be done. But you know, your feedback and insight into actually there's risks of getting this wrong. You know, what we're seeing in core general practice is an increase in both. It's an increase in face-to-face appointments and it's an increase in virtual appointments. This absolutely isn't about reducing face-to-face access where that's appropriate.
Thank you, Councillor Coates.
Hi, yes, thanks for the report. I just picking up on what you were saying about that you're going to be driven by patient insight. Looking at the figures from the survey, if my maths is correct, it only had a return rate of 2.93%. And I'm just concerned that if it was all undertaken by text, alluding a bit to what Colin was saying, is that, you know, it's negating the digitally excluded and possibly the elderly. That's going to be a big cohort using the out of hours services over evenings and weekends with falls and all sorts of things. So I'm just wondering, is there any other ways that you can capture this data other than by text?
Yeah, and we've so I'm not sure what the 2.93% relates to, unfortunately, Tessa. I don't know whether you've got insight into that. We've got an engagement report that sits alongside this, which is based on other approaches to engagement as well. So we do look to engage with different population groups and service users in different ways rather than just through text.
Yeah, it's in the report. 762 patients provided feedback through Local Care Direct survey, and it had been sent out to 26,039 recipients.
Yeah,
so if my maths is correct, it's 2.93%. It's in the report.
So this is the core sort of LCD routine feedback. So, you know, if you visit your GP, you get a text that says rate your service, or if you visit your hospital, you get a text that says that isn't the only information that we've used to gain citizen insight on that, and we can share an insight report with you if that would be helpful.
So are you saying that that's separate to this 2.93% that's being captured by the text method?
I'm saying that the text method is a subset of the total insight that we've got. It's not the totality of it.
Right. So these facts and figures in this report then are not totally based on that survey response.
So the numbers in table 1.8, I think it is based on so that's based on the survey response. So that table in 1.8, because that's the core material that LCD collect as part of their, you visited our service, what did you think? That is supported by a broader range of insight, I would say, that's been done as part of the programme to sort of inform the future work. So it's one piece of information. It's not the totality of it. I don't know, Tessa, whether there's anything you want to add on that.
Oh, yeah, no, it was just to say something relatively similar, that, yeah, that bit that's attached as the appendix is the report that LCD produced and is shared with our kind of contracts and commissioning colleagues on a regular basis, that provides an overview of the engagement that they do. That is not all we've used to inform the Service Development Improvement Plan. Happy to show what happened was Appendix 5, I believe it is, shows our involvement approach and the approach that we've taken to engage with the public to inform the development work that we've done. And so the first part of that was a desktop exercise looking at all the involvement that's been done kind of across West Yorkshire on urgent care services. And we've got a summary of that report, which has informed the development. So happy to share that, but that gives a bit more kind of assurance that no, it's absolutely not just that small cohort of LCD patients who have replied to a text. There's been lots of different involvement that's been done that's not just digital that we've used to inform this. So happy to share it.
Yes. Councillor Rhodes. You're muted, Councillor Rhodes.
Sorry. I know there are lots of challenges around in terms of the provision of health and how people are having to deal with them of late. But it's disappointing when we get a report just that Alison has asked for in terms of the numbers and we're not clear at what the numbers are because we're being told that there are others somewhere else. Now, surely there's enough of you there to actually, when a report comes through, to collate the right information, because, you know, questions are going to be asked. And I'm grateful, Tessa, that you've indicated that there are numbers somewhere else. That percentage of consultation with the public, whoever and however you do it, whether it's through consultants or Health Watch or whoever, it's important that the members know that that's taking place. And at the same time, I think it's also important, and it seems to have got lost over the years somehow, that our Joint Scrutiny Committee is informed on what topic is going out for consultation within the public, whether it be in an individual authority or not, because one learns from the information that's gathered. And then maybe we might have an overall correct answer to the questions that's been asked by Alison. I'm grateful that our chair today, Colin, has picked up on the issue in terms of the wording of everything being done online, as we say it. Everything that we go to of late seems somehow to take away the quality of somebody who isn't IT literate to actually be involved either through paper form or whatever, and is taken for granted. A, that people can now afford to keep up their technology, their monthly payments, or B, that they want to or have got the equipment to do it. Now, that in itself goes back to a paper that we've just been discussing this morning. If that's not part of your old process, that is an inequality. And I'm glad the chairman has picked it up, but I'm going to come back on the words that Ian said about as required. I'm fearful that in the present climate, that this may be taken as an advantageous way of actually reducing face-to-face appointments. Because as it stands at the moment, personal experience, and I'm not on my own, of somebody that isn't knocking on the door every 6 months of a doctor, the average waiting time for people now is between 2 and 3 weeks for a face-to-face appointment. So it's important that the knowledge of what's being looked at, and I hope today, and I'm sure it will be, as a result of the chairman's concerns and mine, which I'm grateful to him for expressing, I'm hoping today that the response is going to be minuted in terms of that this is not going to be used as a way of taking people away from the ability to have a face-to-face appointment. And I think that's really important that that is said and is kept being said over every review that we have, because I'm all for going forward with any change that may help, but I'm also very keen, as we all are here today, to point out inequality is right across the patch in terms of affordability, that people can automatically think somebody has an iPhone or all the rest of it. Well, the real world out there, that doesn't happen. But I'm grateful for you asking that question, Chair. Thank you.
Yes. And I would ask that response had been minuted, as Councillor Rhodes has explained. Looking at the timeline diagram, obviously you've come to the point where you're going to be signing off the service development and improvement plan sometime within the next few weeks. Is that correct?
Yes, next month.
And then there's another bar that says public consultation if required, extending after the pre-election period. So what kind of public consultation is this? When you say if required, how is the decision taken as to whether it's required or not?
So yeah, Thanks, Councillor Hutchinson. So just to say, hearing yourself and Councillor Rhodes loud and clear about unintended consequences and exclusion, and it's really helpful to have that reminder, and we will ensure that that is fully factored into the work. So what the SDIP is, it's almost a kind of a set of areas where we want to prioritise further work, and when we get into that work, we'll probably, we'll continue to do the appropriate involvement and insight work with citizens on that, and that might lead to outcomes, differing outcomes or different proposals. So, for example, if there was a proposal to change the number of urgent treatment centres that we have, obviously that would be something that would be subject to consultation. We're not at that stage yet. What we've done is we've identified a set of further areas that we want to work on within the timescales described. We're not at this point saying we need to go to public consultation on any of this, but that is an eventuality that might result from the next stage of the work. Clearly, if we do go to public consultation on any aspect of this, we'll engage with you early in that process, and it might be that it's a local issue rather than a West Yorkshire issue. We'll continue to engage on that basis.
Thank you. As you know, in both Councillor Smage and myself have raised concerns about the safe haven or services special allocation scheme that operates in Calderdale and Kirklees. Looking at the report, I'm none the wiser as to what is actually going on in those discussions. It's talking about scoping the service early in the new municipal year, and then working with commissioners on future strategy and plans fairly shortly after that. At what point could we, if there are strategies and plans around that, or to change that service, which I see as being really important, that and it's dealing with 2,000 consultations a year. At what point do we get some kind of insight as to what is being discussed?
Yeah. So the intention is to do that scoping work in Q1 of next year. So we're talking about April, May, June next year. So when that piece of work is being completed, we can we'll be in a position to share more information on that. The work hasn't been done yet, Councillor Hutchinson.
You mean next year being April, May, June 2024 or April, May, June 2025?
April, May, June 2024. So in the next 3 months.
Okay. So this is something we need to get back possibly to the job. Does that just have an impact on Calderdale and Kirklees, or is this a service that's used for potentially dangerous or aggressive patients from West Yorkshire that just happens to be based in Calderdale and Kirklees?
So it's a Calderdale and Kirklees service. So in terms of scrutiny, I think there's a question about whether that would just be picked up through those local arrangements. I mean, the GP out of hours service, as you say, is the bulk of this, and that is a West Yorkshire service. Most of the additional services, like the urgent treatment centres, SAS and so forth, are local add-ons. So if there was changes to those being proposed, I think the conversation would be about whether the local scrutiny arrangements would be more appropriate for those.
Okay, I'll ask for it to come to the local scrutiny board within that work plan. Right, thank you very much. And in terms of, I mean, given that the sign off of this is happening imminently, I don't know that there's anything that we can say very much apart from sort of noting it and making the and minuting that we're concerned about the potential for digital exclusion, and would and that we've raised those concerns with you. Councillor Rhodes.
Thank you, Chair. Ian mentioned development plans. And I think most times the word overview is forgotten in terms of the work of scrutiny. In the development plan process, could I ask through you, Chair, is it possible to have this as an overview, culminating then to what is going to be the final draft or final planning process? Because sometimes if through overview we're informed, then at that particular time it's always useful to know that the plans or processes are aimed at the right direction for care, or B, that maybe they need tweaking in terms of, local plans, or indeed where situations may arise, as we do know through the joint process, where a knock-on effect may actually happen in the next door place. So I wondered if that's a possibility in relation to the plans, Chair, as an overview.
Are you thinking about a review in about 6 months' time, Councillor Rhodes?
Indeed, Chair. Indeed, yes.
I agree. I think we should factor that into the work plan for this committee, because as we've noted, it is what happens out of hours particularly is extremely important, the overall service that people receive, and there are so many ways in which the wheels can come off that, and so indeed.
Thank you, Chair.
We'd be very happy to work with colleagues, Yolanda, Laura, etc., to schedule in an update at the appropriate time. Thank you. And thanks for the comments on that. That's really helpful.
Thank you,
Councillor
very
Hutchinson,
much.
I've just messaged Kate Sims, who's our Director of People, and Jonathan Brown, and they're going to be leading the next item for us, so they'll be with us any second.
Okay, lovely. So we will be moving on to that. Let me know when they actually appear.
I have messaged, and I know they're on standby, so I'm thinking it's going to be second. Sorry, I always feel the need to fill in this this quiet time, but they'll be here any second. I think Yolanda's got her hand up to fill some of the time as well.
Yes, Yolanda.
Hello, Colin, through you, Chair. I was just thinking, being as you've all started at 9 o'clock this morning, we could just put a hold on the meeting, a slide, put the hold on the meeting for 5 minutes, just to give everybody a quick comfort break, and that'll give chance for our colleagues to come back if you want to do something like that.
Yes, that sounds.
Alternatively, we could do the agenda plan first. Either of those.
Okay, yes, that might make sense.
Oh, they're here now. Actually, by the looks, they're here.
Well, welcome, Kate.
Hello. Good morning. Good morning.
Yes, thank you for joining us for this item on an update on the West Yorkshire workforce strategy, or how it's panning out. You can take it as read that members have read the report that you've given. So it's just whether there's anything additional that you would like to tell us, but I'm sure we've got quite a lot of questions about the report.
Okay, thank you, Councillor, and hello to everybody. I don't believe I'll have met many of you. So just to introduce myself and my colleague who's just joined us on the call as well. So as you'll know, I'm Kate Sims, so I'm the Director of People for the West Yorkshire ICB. And hopefully most of you can see on the screen, Jonathan Brown is a member of my senior team. Jonathan is my Associate Director for Workforce Strategy and Planning, which I think will probably be a key focus, I suspect, of our discussion with you today. So if it's okay with you, I absolutely, yes, I wouldn't plan to take you through the paper. So thank you all for taking the time to read it. I guess just some headlines, if I may, and then we can perhaps enter into a conversation. It would go without saying, and I've said the same to the ICB board and the West Yorkshire Partnership Board when we've talked about the people agenda. Of course, it's a very vast subject. And I absolutely would estimate that there will be things that you wish to discuss today that we might not have the answers to, but we can always look to take those away. The focus we were given was to ask, to just sort of describe to you the priorities, and I guess importantly how we come to some of those priorities, both as an ICB team, so my own relatively small team in the People Directorate, but also we work very much across partners. I think it would be remiss of me to assume that we can lead the people agenda on our own. Workforce challenges are significant, it goes without saying. I think there's some immediate pressures for us in terms of growth and how we go about the growth of our workforce. That there's an awful lot of focus locally and nationally around retention and how do we not just retain our people and look after them, but develop them into new roles. But I think for me and my team, and particularly in Jonathan's team, there is something about what's our longer term plans around the workforce. You'll have seen hopefully before, but it's there in the paper that we do have a West Yorkshire wide people plan or people strategy. It's a multi-partner, multi-sector strategy, and then each of our places really do focus on what that means for each of our the parts of West Yorkshire. And I chair the West Yorkshire People Board, which has an oversight of how we're doing against that. We break it down each time into themes because, again, the people strategy is very wide-ranging. If I can just say briefly, I think just to clarify, how do we as a team, as the ICB team, firstly, undertake a focus on our priorities? Well, firstly, if I look at for a moment the long-term workforce plan, which some of you might be familiar with, that's been launched in the NHS, I think the quote that's on page 4 of our paper around the size and shape of the workforce needs to change to meet patient need. And how, we obviously ensure we've got enough people with the right skills in the right place. I said at the last People Board meeting last week, you could take the word NHS out of that and apply it to all parts of our sectors or all of our workforce right across, which all of the partners on the People Board agreed. And take the word patient out and talk about our local communities. And that's how we apply. So in terms of our local priorities, yes, some of those are driven by national guidance. They have to be. So the long-term workforce plan is a key example of that. So, within the NHS, of course, there are annual operating plans. We have to develop annual workforce plans and annual financial plans. But also, of course, you'll know locally, we have very significant work integrated care strategy for West Yorkshire, a joint forward plan that I'm sure you've heard about and discussed with my colleagues. So it's all about, well, how do we respond to what West Yorkshire needs of us? And some real examples of that have come out of the ICB board include dental. Oral health became a real priority focus, and I appreciate from a workforce point of view it's not the only one, but so one of Jonathan's team's top priorities is to help, and they have done, develop that workforce plan across oral health as an example. So we are guided by what West Yorkshire, what the focus is, as indeed the digital strategy. So some parts of the paper hopefully give you an insight into what my team particularly focuses on. So Jonathan's area is absolutely working closely with me on the start of our long-term workforce plan response. Obviously, I've mentioned the dental workforce, and they are very much focused on the digital readiness of parts of the West Yorkshire workforce. And then I've mentioned my other teams in the paper because I appreciate this is the first time that I've been here to speak to you. But my own overview, of course, is very broad. And in addition to what the team focus on, you mentioned the People Board, I have a very specific role, for example, around the wellbeing agenda. We have a mental health, a West Yorkshire
Sorry, Kate. We are of limited time.
Okay.
So,
okay. Yeah. Right.
You know, I do want to give time for members to raise.
No, that's absolutely fine. That's absolutely fine.
Unless there was something very specific that you wanted to tell us.
I think the key message for me would be that we work very, very closely with all of our partners across health and care in West Yorkshire. So it isn't just for me and Jonathan to lead their people strategy for West Yorkshire on our own. It'd be remiss of us to assume so. So if I look right across our sectors, if I look at the membership of the People Board, for example, we talk about things like workforce planning and the development of growth. Well, a huge part of that is about placement, clinical placement capacity. And as the paper goes on to say, for example, we don't assume that's only in hospital providers. The graph suggests that's where it has been. But the work that we're doing is very much working across our communities as well to say where else, and working with our education providers as well. So I guess that's just one example, councillor, of, you know, this is what we do, is we don't deliver directly. We work very much to facilitate and support our colleagues in doing so. But happy to take questions if that's better.
I'm concerned that I can't see. Appendix A sets out that we're getting more of everything. But more doesn't necessarily mean enough. We know we're constantly being asked as scrutiny boards to be looking at service reconfigurations, and the driver for almost all of those is lack of the appropriate skilled workforce. Currently we're looking at non-surgical oncology because we don't have enough oncologists in this country, apart from in London, where there's big private practice and commercial incentives for people to work. We don't have enough of the cancer nurse specialists to provide in the service. The data that you've given us is very, very high level, and it doesn't give me a sense that we have a grip on where the key deficiencies are in our workforce, and a strategy to actually address that. I mean, we know midwifery services are struggling. Now, midwives are lumped in here with nurses in terms of this. Has there been a growth in midwifery places? Do we have enough of the placements to actually train the people coming through? In terms of medical specialists, we know that the outputs from medical schools are increasing, but when you come out of medical school, you are not the finished article. You're not much use to anybody. You need the specialist training from that, whether it's in primary care or whether it's in any of the other surgical or medical disciplines, to actually be more than an ornament. But we know that for almost every training place for specialist training, there's 3 or 4 applicants for each place. There's a huge bottleneck at that point in the system, which is meaning we're not getting the consultants with the appropriate skills available to keep our services running. I can't see any kind of acknowledgement or detail of that in the report. So I presume we do know where the gaps are and have a strategy, but maybe I'm assuming wrongly. I would like to see it set out in detail.
Thank you. Well, thanks firstly for the feedback. And as I said at the beginning, councillor, that's what we focused on. And in doing so, we thought it was very important to share with you that overall, certainly from a health perspective, the workforce has grown. I believe what you're asking is, do we have a detailed workforce plan? And of course, the answer to that would be that's a lot of that, not all of it, but a lot of that is shaped by what we call the annual operating plan. So at this very moment, which will be signed off by the ICB board next week, is the annual workforce plans for every discipline, every specialty, every growth within all of our health providers is the first thing to say. And that's something that Jonathan's team would be very much working closely with. We're responding to questions even today around disciplines within each of our organisations at that level of breakdown. So there's something firstly about that in-year, 1 year exercise. There's something else that we've been working closely with each of our 5 places on, which is the multi-year workforce modelling. And this is absolutely across sectors, across disciplines. So typically, whether it be, you know, Bradford, Leeds, Wakefield, whichever of our places, this is that multi-sector look at the workforce plan to say some of the points that I think have been raised in the paper is it can't just be a focus in one area. So that level of detail, you know, would be there. But of course, what you're raising is I think we acknowledge some of the challenges about placement capacity. And one of our big priorities, and we see the long-term workforce plan as an opportunity about this, is to ensure that we've got placement capacity. It talks briefly in the paper around community services, for example, out in communities, rotations. I'm liaising, as is Jonathan, directly with, for example, if I take medical students with our Leeds University Medical School, any growth in capacity, directly linking with all of our trusts to say, who has capacity for further growth so we can be ready to respond to this. So there's a range of activity, and I absolutely appreciate if this paper was focusing on what we're doing about workforce and the plan and the future, you would get more of that detail, which I'm sure going forward we can focus on. Just conscious, if I may, before we've answered that, Jonathan, I know you very much are involved in this. Is there anything you feel that I've not done justice to in terms of that kind of layering?
I think in some of those specifics, Councillor, you mentioned non-surgical oncology and cancer nurse specialists, there is plans within the cancer network to tackle those challenges. We in the People Directorate have a global partnerships arrangement, and we've been supporting some of that work around non-surgical oncologists with an international recruitment programme, working with the trusts, specifically Calderdale and Huddersfield, in trying to develop a pathway to bring additional oncologists in. But that, given the size and scale of work that my team can do, given it's so small, that plan responsibility does sit with a workforce team that's within the Cancer Alliance. So there is a big priority on that cancer workforce and more detail within their plans. Postgraduate growth, I think it's fair to say that in both primary care and in secondary care, the evidence is that since 2018 we've grown postgraduate spots for an increase in trainee doctors quite rapidly, and we continue to do so. I do meet with the postgraduate deanery team, and we talk about that expansion of medical intake into Leeds University as well. So Kate indeed actually leads a meeting with Leeds University on a regular basis, and we're currently working up a workshop to tackle some of that growth that we need to see in the medical, which will include the postgraduate world. We recognise we can't do a pathway.
It has to.
Yeah, we can't. We recognise that. I mean, I started my career in the postgraduate world, so you know we have got that knowledge, but we haven't got a massive team, so we have to work with our partners to pull all that together.
But there's been so few, across the country. There has been so little expansion of that of those training places, specialist training places. Health Education England have tinkered around at the edges very much.
We've seen an increase in doctors of 27%, Councillor, since 2018. It's been significant growth in the medical world.
But not. Can you just reassure? Has a gap analysis been taken place across the Integrated Care Partnership as to where the gaps are in our workforce?
In its entirety. So
in its entirety.
So yes, in the way that Kate described. So you have both an operational planning round where we identify exactly what workforce we have, what gaps there are, what can be afforded. We're having to cut the cloth to fit with the finances. But trust individual organisations will understand those gaps. When it gets to us, it comes up in an accumulated fashion so that we get plans from every single organisation that we then see at a top level. So on an operational level, year on, we're balancing workforce numbers against finance. Have to be honest about that. That's the world we live in.
But obviously, if you're training up a professional for the rest of their life, we're not looking at year by year to year.
No, absolutely not.
Gap.
No,
we need a strategy that's looking at least 5 years ahead.
Yes,
where can we find that information as to where the gaps, what the gaps are, the size of the gaps, and what is being done about it?
So. Sorry, Jonathan. I guess that there's two aspects here. One is the work I'm familiar, Jonathan, you're familiar with about the METIT rounds, and we look at the long-term training numbers across all of the professions. So this is understanding, because obviously whatever we say we need today, we recognise that in some areas it could be a number of years before people are ready to actually be deployed. So that's the first thing. So we have something with our regional colleagues that's fed upwards in terms of medical education across a number of professions, that's all fed upwards. The other thing is we have been awaiting, and I'm involved very happily in the national start of the same for social care, but we have been awaiting obviously now the long-term workforce plan, because there's something about growth numbers but also understanding about funding streams for that. That has now been published, and we are all working closely on what does that first year of 25-26 in terms of development start to look for. We've given you in the paper an indication, and it is a working assumption as opposed to hard facts as to where we think the growth will likely come from the long-term workforce plan. And what we absolutely have to do is tie all those things together. So there's a range of things that feed into this. There's the annual work that we've described. There's obviously our work with the regional teams around that medical education pipelines across a range of professions. But then there is this long-awaited long-term workforce plan piece, and it's what that looks like, because that's a 15-year workforce plan. So it will continue to evolve. It is evolving at a regional and local level as well as nationally from that point of view. So I'm not sure that fully answers your question, I'm afraid, but
no, it doesn't, I'm afraid.
But that's where I feel that we are. We have to continue to evolve the work that we're doing about where is the demand and where is the opportunity for growth, but tied into sort of obviously university placements. There's a huge push going forward on apprenticeship strategies, for example. All of that has to be built in together.
Thank you. Councillor Addy?
Hi.
Hi.
Yeah, I mean, it's great to see these percentages that say increase. Now, it doesn't actually, I may have missed it, but does that it says increase in workforce? Or is this an increase in the number of new people? Because 20% more new people is a lot different to 20% increase in the whole workforce. And also, it seems like to me that there's a column missing at the end. So where does that match up to filling the deficit? So there's no reference. There's 27% more. Is that 27 more new people or 27% more people in the workforce? And what is left then? What are we still missing on each of those rows? And I do note with worry that nurses are all lumped together as -4, 5 nearly %. Including many people, perhaps midwives and things like that as well. That it could be broken down a bit more, maybe, so that we're a bit clearer and can be more focused.
Yeah, thank you. Well, the first thing to say again is that appendix is just to give you an absolute overview. We haven't broken that down into every profession. So just for clarity, where you've mentioned there, councillor, around the nurses, that's nurses within general practice. You'll see in the higher box that in nurses in general, there's actually been, you know, a 14.6% increase. So which
is that
would
new or overall?
So this is increased to the overall workforce. So in other words, if you look back at December 18, what did the workforce numbers look like? And then you look at December 23, and you can see for nurses, for example, in our trusts, that they have grown by 2,099. Some of those, in terms of, to answer your question, will be brand new into the workforce, you know, additional people who've qualified. Some will be people who've returned, and retire and return is now quite a, you know, a significant process as well. So it will be a range, but yes. What we're showing there is overall, has the workforce across the system grown in health? Yes, it has.
Can I just, yeah. And what about the end result then? Where does because it might be an overview, but if there's 27% more, how much are we still lacking? That would really be the ideal final column to this.
And this goes back into the conversations we had with the previous questions, which is what does our in-year operating plan look like? And you know, we're doing that very much now for sign off next week. And what we can see is that in some of our trusts where they had perhaps a workforce plan even for the year that we're just ending, that they haven't quite matched that. So that would show the gap you're referring to. Others have exceeded that. They've actually increased their establishment slightly more. So I think, again, what you're referring to is what's the breakdown. But then we get into the breakdown at what level. Is it by organisation? Is it by profession? Which, you know, again,
well,
that's something we haven't covered here.
Would be by profession, and it would be a exact thing to say. You can increase it by 27%. We've only had 5% of the workforce available. That 20% of the 5%, it's a tiny bit. If you've got 90% of 95 or 99%, a 27% increase is massive. It is meaningless unless we have that final column of saying where are we, where does that leave us? Where are we at the beginning? Numbers increase. Where are we at the end? What's still missing? Or what's come up to me, that's like, it means this. It's lovely. It's great that we've got more people, but it's not meaningful. That 7% more. I don't know how many. Let me see on the first one. You know, medical and dental training, including training grades. I don't know what that first figure is. Is that how close to fabulous and 100% is that? I've no idea. So the end column missing is, to me, means that whilst it's all positive, it could be just tiny bit. It could be a drop in the ocean positive. Can we have that?
Well,
I think
sorry.
Ian Holmes, do you want to come in at this point?
Yeah, I mean, maybe just to offer a reflection. I think the numbers have gone up, and those are, you know, those are the sort of the aggregate numbers as described. What we also know is that the length of time that people wait has gone up, and access to services has got poorer. And you know, and to be blunt about this, a big part of the constraint is money, as well. So we'd love to say, look, you know, to get to waiting times to, you know, 18 weeks rather than 18 months, which was the aspiration 15 years ago. You know, this is the amount of expansion that we'd need to be able to do that. If we believe that's the kind of the level of service that we should be aspiring to. But clearly the you know, the financial context that we're working in as an NHS isn't there to allow us to do that. So you know, it is quite a complex you know, thing to try and do. The other aspect of this is productivity, and clearly understanding organizational productivity and workforce productivity is a really key part of what we need to do, because, you know, as I say, given the constraints that we're working in financially, doing more with the same is a massive part of the challenge here. So it's not quite as simple as saying what would we like to aim for, because we're operating in a system where there's, you know, an awful lot of constraints, as we all understand.
Right. Okay. Councillor Swift.
Yes. It sounds like we've got quite some way to go to get back to where the old regional manpower planning, back to where the old regional health authority was. And I think as far as this meeting's concerned, I think we've got quite a chunk of unfinished business. I think we probably do need to ask our ICB colleagues to come back on another occasion, and possibly with a little bit of attention done from our end in between to kind of highlight the areas where we do want more information, or you know, in a bit more depth, because certain aspects of all of this, certain aspects, I think are quite critical. I'm thinking in particular of the aspects that require coordination either across West Yorkshire or wider, and timescales, and some of those, even if the output is going to be kind of 5 years hence, if we do something next year rather than this year, then the output becomes 6 years hence rather than 5 years. You know, the further into the future it is, in some ways, the earlier we've got to actually start. But yeah, as I say, I think we need to come back to it, and we need to come back to it in some detail. Thanks, Chair.
Thank you. I would agree with that, because time is pressing on. We've not got very much longer for this meeting. Councillor Rhodes.
Thank you, Chair. I agree totally with the view that you gave of the paper and that of Councillor Swift. Workforce planning started in the shadow board before the ICB became the legalities, we'll call it. And I'm just wondering, Jonathan, you look so familiar. Were you there at the time when that working group was set up?
I don't think I was, but I did.
No, okay, that's fine. Well, it might have been your twin, love, but you just look like the person that was leading it. But that was set up.
I used to lead workforce strategy and planning for Yorkshire and the Humber Strategic Health Authority.
There you go. There you go. I found you, love. I found you. Anyway, I think that a headline, forgive me, and we're all eager to have a good workforce, and the financial climate that you're all in, we do appreciate the challenges. And I know that there's a group of people, 3 of them, they came to my committee, and I was just trying to remember their names, because they've got a commission for a 3-year contract looking at the work programme and working issues. Now, Councillor Addy has hit the nail on the head. We're playing semantics here with percentages. What we need to know is, to begin with, in terms of the different areas, if you say doctors, if you say nurses, if you say oncologists, which seem to be very much lacking, you have got main disciplines that will feature in the healthcare of individuals. And it is those figures that you can't play semantics with, because some of those, in terms of the nurses, the shortage of nurses, the shortage of doctors, the shortage of specialists, as Councillor Hutchinson has said, is a main part of it. So you can't play semantic with percentages. And I have to say, at this particular time, having worked in the health service for 20 years, I am, from constituents, so delighted to hear them say that with the student nurses complementing staff on wards, if it wasn't for the student nurses being there, they don't know what kind of care would have been given. Now, and that particularly is relative, very, very relative to adult care. And we all have very, very grave concerns about adult care. Now, in your figures, and if we're going to play semantics and say 27% is brilliant, well, 27% is what, as Councillor Addy has said? I don't think that you're actually, through your workforce planning, identifying, how many vacancies were in it originally, how many of those are new recruits, how many, if any, you are actually including in the nurse trainees that are on the ward, the student nurses. That hasn't been mentioned, because I believe me, the wards wouldn't work without them. So where this massive 27%, which means a headline that's good for somebody, but very, very negative for people using the service, why is it not that the bureaucracy in terms of getting work done that's been going on since 2019 within the ICB board connected to the legality of it. Why is it that we're not seeing the specifics that are there in terms of what principles, what part of the profession is got some growth in it in replacement? Growth is not a replacement. And I think that's something that we've got to sort out. And I do think that the overall presentation of this report today leaves more questions to ask in terms of what is being achieved, because when we're on about scarce resources, and this is not to anybody, believe me, resources can't be wasted in looking at situations that have been looked at before. And if that wheel needs stopping, instead of the wheel turning, let's get somebody in there stopping it, turning it, and getting the information that we want. And it's important that we support you in all that you do, but there are challenges there that have been identified that there hasn't been an answer for today. And I support it coming back again, Chair. I'm conscious of time, but I think the breakdown of information has not got to be graphs, because that some of it we can't see. I have a question about the way the report has been presented, and I believe that it can be made more user-friendly, because somebody out there looking on this report, the public, who will be looking into this, will not have a clue what's happening. Not have a clue. But don't let's make headlines with things that we haven't been able to substantiate. As Councillor Adey started, let's get the issues plain. What vacancies were there across the disciplines? What growth has there been in them? What percentage is replacement? And then when you come to the icing on the cake, is, as Councillor Adey says, you're looking at the 90-95%, which God knows within these challenges time, I wish everybody the best of luck of getting it. But let's bring it back, Chair, you're quite right. But thank you for being here today. And I think sometimes the reports that are put to committee, we have to be conscious, and we have to be aware that we're here today for the public out there to get some information, not to be baffled in brain power as to what everything means. But we do appreciate the challenges that you are facing. Thank you, Chair.
Yes, it is a difficult juggling act, and it's difficult to present the level of detail that we actually need to know that the partnership has a grip on the workforce issues, because when there's 120,000 vacancies across the NHS in England, how many of these figures where we talk about the growth of workforce, how many of those are filled substantively? Are these all people who are actually in post substantively, or are those posts that are being recruited there to be recruited to, should there be a suitable candidate around? I think we need some definitions amongst that for that table in Appendix A. Councillor Adey?
Just briefly. Yeah, so what I heard there was working assumptions, the words, and this is 2018 to 23, so not assumptions. This is fact, just not giving in enough detail. And I do appreciate that you haven't got the money to go do it, but we can't lobby as politicians and go away and fight for money and ask for money and beg for money for the things that we need if we can't identify the priorities and if we can't see the holes at the end, because these figures look fantastic as plain numbers, but we can't see the holes at the end and ask for it and demand it and push for it. If that's not there, we can't back you up to get more if we can't see those holes ourselves. And I was just looking at the international level. I mean, how is the deals with Europe now on that? We're looking very far afield in Uganda and is it Kampuchea? I mean, it's great, and international input's great, and it's a good way to fill that. But have we lost something with the difficulties that we're having to get things in from people in from Europe and stuff as well, closer, more handy?
Kate, do you want to come back on that?
I know you'll be wrapping us up at the moment. Firstly, thank you for the feedback. We take it very seriously. I think what you've all demonstrated is the challenge, which is the size of the workforce agenda is vast. I've sensed today what the focus has been on is one aspect of this, and apologies if colleagues think that, you know, we've just given you some very high level figures. We were asked to present what we felt were our key workforce priorities for the first time, which is what we believe this paper does. The focus feels like it's been on workforce planning particularly. We understand that it's a key part of our agenda. It's only one part of it, but it's a key part. So to request, as I think Councillor Swift suggested, we would be happy to come back and go through some of those details, but we would really plead that there is some specific questions about specific workforce professional areas, because even this, you know, we could talk about international recruitment, we could talk about certain professions, but we won't do justice to every part of the system in a half an hour, you know, discussion with you. So if you've got some specific areas you really want us to focus in, please let us know. I think that's the offer. Thank you very much, or the request.
Yep, no, certainly be delighted to compile a list from members that will hopefully give some guidance as to those areas that are of most concern. I would like to just point out on that table, though, before I do wrap up, that there looks to be now almost parity between the number of physician associates with the number of GPs. They're all getting close to being one physician associate per GP, which I know the Royal College of GPs, after their council meeting last Friday, issued their concerns about the use of physician associates within general practice. So just you know, interesting to see the figures there. But thank you very much for your input, and we will be inviting you back to another meeting fairly shortly with a list of areas of concern that we'd like you to focus on. Thank you.
Thank you.
So
thank you both. Thank you all. Thank you.
So thank you, Jonathan, as well. So before we finish, it's the workforce. There's the work plan for this committee going forward. There's been a couple of issues that we will be revisiting from this morning. Are there any other comments that members have?
Just in terms of the workforce plan for ourselves, for the items on the agenda, they may need, Chair, in relation to the topics that we've discussed today, another perusal in case we have to reprioritise. We don't have enough meetings in the year to accommodate everything, but when we ask people to come back with information, I think we've got to be courteous enough to make sure that we put those on the planning process for them. And I'm sure yourself and Liz will be going through that to see what we need to prioritise to bring those people back to us.
Can I ask members, and I know I'm conscious that there are 4 members who've not been specific areas of the workforce planning, workforce strategy that members would like us to include in that list. Can you email me, and I'll try and put it together into a meaningful list prior to the next time we invite them back.
I think that's very relevant, Chair. And just to add to it, I don't think we've got to go through the process that I've gone through today. I think the questions that we've all asked, surely each trust covering our area have themselves got information where they have got gaps and where we're having to employ agency at a higher premium. So from today, maybe it's worth considering just to get back and say to them, the trusts that cover our individual authorities across the patch, that we'd like information from them in terms of the disciplines within their provision that have gaps, and we are having to have a big part of that will be they're having to cover them with agency nurses at a higher premium. And I don't think that that's going to be too much for anybody to put together. And on top of
overtime. Sorry to butt in.
Go on, love. Yeah.
But overtime and agency, you know, where people are working extra shifts and stuff. So that will identify where the gaps are, won't it?
Exactly. And when we're looking at a combination of the trusts and the provision of health, we generally focus on the medical health, the physical health. But on top of that, we have overarching trusts that are at present dealing, because of crisis in the community, they're dealing with mental health provision as well. So I think we just can't focus without thinking of the whole being, and basically that's our issue, isn't it?
Yes, absolutely. Are there any other comments on the work plan for the committee at this point? Otherwise, and if there aren't, then I'll thank you all for contributions. Councillor Coates?
Yeah, I just wanted to mention, because we were given a paper about the types of additional support, like the associate physicians, and you know, I'm quite concerned in terms of what that report highlighted about you know, the gaps being filled by other associated practitioners, where there have been some quite high profile things in the press about fatalities as a result of not getting the right advice, and I've got some concerns around that, which we've not had time to sort of discuss, and I don't even know if it would have formed part of that discussion. But the paper was sent to us, and I read it with interest.
Well,
do you think that discussions about the use of physician associates are best done at West Yorkshire level or at individual place scrutiny?
Me personally, I think it at both, because I think it's a subject that you know, needs highlighting.
Well, particularly you're right, because particularly after the view that's come out of the meeting last week, where it's a one-to-one, you know, between the associate or the GP, and this is where I think when we hear percentages across the patch, you know, they've all got to reflect the corporate being there who's providing that service. And at the moment, we're all very concerned, as you say, about the expansion of the position within the doctor surgeries, as well as the dependency that seems to be given to some of the excellent students that are in their third year. They are absolutely excellent. But I think we've got to, I'm sure you will, Chair, with Liz when she's better, have a discussion that we target more questions. They wanted more questions, so let's target it to various disciplines where we all think collectively it's nurses on the wards, it's the professionals, it's the support teams. And on top of that, we're all conscious of the policy in terms of bed capacity and the turnaround from people being discharged from hospital late at night. I have found out through the trust and asking in my committee, we used to have a time at night, and Kevin is here that can actually support it. We used to have a time at night whereby any elderly person was not discharged home after 8 o'clock if they were vulnerable. At my committee, we asked it of late, and the answer I got is they do not have a time now by which they have to commit somebody having to stay in the hospital. If somebody can go home, they can go home. And the other part about that as a discharge is, and I know through a family member of my own, the problem with that then, if there's a discharge at night time and the physical needs of that person is not taken into account, where they may need an ambulance, there are shortages of ambulance because they're on emergency care at night time. And it seems to be a vicious circle. And one thing that I'm sorry if I'm going on, but one thing that really does, I think, get to me at times, we have these reports. Are they meant to baffle us, or are they meant to engage us and inform us?
I agree.
I'm sorry, but it does, and you know, we have to do that from the overview point of how reports are presented. I do not want working documents to be presented to me as a report. And particularly when you can't increase the size, you can't see the colour, they're making pages up, and I think we'll do as they asked. I think we'll do as they ask, get some questions together on the disciplines.
Yes,
Yeah,
will
I mean,
encourage members. I think we're still on live stream.
Yes, that's fine.
I will just say the reason that I'm highlighting that is because I've had a constituent in my ward raise an issue with me about this not seeing a GP and being given wrong advice, and it's ended up with her in a really bad situation. I won't say while we're being live streamed,
No.
but believe me, it's relevant to raise it.
I think it's right to respond to the questions that they've asked, Chair, in terms of direct questions on disciplines, on shortages across the trusts. That information must be there, and I think that would be informative for us as well as any of the public who are listening today.
Yes, I agree. Although my experience of trying to get that information from the trusts has not necessarily been an easy one.
No.
So, okay. Well, thank you very much for all your valuable contributions. We'll try and put this together into sort of suitable additions to the work programme for the next municipal year. But,
thank you, Chair, and best
well,
wishes. Best wishes to Councillor Smage to get better.
Yeah, thank you.
Bye.